slide I have highlighted the words that are important because debates are all about words. One is management. Second is type 2 diabetes. We are not talking about any other type of diabetes. We are talking about type 2 diabetes. And third is what is more important. And that is what we are going to talk about. And I am going to fight for weight. Now, I have 5 points, 2 slides each point, 2 minutes each point. And those 5 points should make everything crystal clear about what we are talking about. The disease type 2 diabetes itself originates from poor management of weight. We are not talking about obesity. We are talking about improper weight. It could be less weight also. It could be sarcopenia. It could be malnutrition related diabetes. So what we are talking about is improper weight or poor management of weight. More specifically termed as fat. Not the weight of muscles, not the weight of organs, but the weight of fat. And what can go wrong? The amount of fat can go wrong. Fat can be higher, fat can be lower. It can be abnormal deposition of fat. Fat where should not be there, the fat is there. That is visceral fat. And abnormal functioning of the fat, that is adiposopathy. What we are talking about, brown fat, white fat, the fat that is not participating in the metabolism. Because fat is an extremely important storage, metabolic, endocrine organ. And if it is not functioning properly, that is the result of, that will result into the disease called type 2 diabetes mellitus. So glucose is not the original factor in the pathophysiology of the disease, it is weight. This is point number 1. And that is why high glucose in type 2 diabetes is a result of disease process and not the origin of the disease or the disease itself. We identify type 2 diabetes with hyperglycemia, but that is not where the disease starts. That's the point number 1. And unless we heal the root of a problem, the pain will not go away. You can hide from it, but the problem stays until you dig deep. So we need to work on the deeper problems with type 2 diabetes, and that is weight. Point number 2, type 2 diabetes is a multifaceted disease. High glucose is just one of the outcome. So just managing one outcome of the disease is not going to suffice because the residual risk after glucose management remains. And probably the only most impacted factor with hyperglycemia is retinopathy. Rest of all the complications are not completely managed by just managing the glucose. And those are stroke, myocardial infarction, heart failure, cardiovascular disease, obesity, cardiorenal disease, peripheral arterial disease, biomechanical problems because of excess or poor weight. So these are the factors that are always associated with type 2 diabetes mellitus, and just managing glucose is not going to suffice in managing those disorders. So this is point number 2. Point number 3, when I have somebody with hyperglycemia and abnormal fat, then my first try would be to remit the disease, not just to control it by controlling only glucose. So I would like to work on the patient's weight, including right composition of muscle and fat. It's not only about loss of weight by giving less kilocalories and less carbohydrate. It is about managing the weight properly so that the patient has a right body composition, and then the resultant metabolism will result in normoglycemia automatically. So if the person with type 2 diabetes comes to me, my first attempt would be to try to see if I can remit the patient. If not, then at least control maximum with management of weight, and then if required, add a couple of or a single anti-hyperglycemic agent to manage the diabetes. So more important here would be weight. So this is point number 3. Point number 4, focusing on weight is pleiotropic. Now till now we talked about the disease. Now I am going to come to the treatment part of it. When you saw that hyperglycemia is only one aspect of the disease, likewise if you manage hyperglycemia, you only manage one aspect. But when I manage weight, I not only manage the metabolic complications that I saw, that I've seen shown in the previous slide, which include other metabolic parameters, which include cardiovascular, cardiorenal, and cerebrovascular disorders, peripheral arterial disorders, heart failure. These are all metabolic complications associated with the disease that we call as type 2 diabetes. Apart from metabolic disorders, abnormal weight is also associated with psychological problems, which will not get affected with just being obsessive about HbA1c. I have seen people being so obsessive about HbA1c and controlling the glucose that they stop eating, they start going for walks like nothing without understanding what they are doing. And that does bring down the blood glucose, but that doesn't treat the type 2 diabetes properly. So that is not something that we should be obsessed about. We're not obsessed about HbA1c. We need to deal with the disease, which is not only metabolic. It is also associated with psychological issues. It is also associated with biomechanical issues. So excess weight or abnormal deposition of weight is very commonly associated with knee osteoarthritis, changes in the foot architecture, then foot problems in the future because of biomechanical abnormalities, low backaches, trapezius spasms. So these are also the factors that are very commonly chronic pain associated with muscles. These are also very important diseases which come along with type 2 diabetes. And if I only manage glucose, these are going to be left alone. And that is why weight is more important in management of type 2 diabetes. This is point number 4. Point number 5. Managing glucose without giving consideration to weight is going to be harmful. It is going to be contradictory to what we are trying to do with the disease. If I use therapies which manage hyperglycemia, which increase weight, we know that there are therapies in type 2 diabetes which reduce glucose but increase weight. These are going to be detrimental to the patient's future and the pathophysiological process. So if I do not consider weight when I manage per people with type 2 diabetes, if somebody who is obese coming to me with a very high HbA1c, and if I treat this person with sulfonylurea, if I treat this person with insulin, the patient is going to gain weight, which is detrimental to the future and pathophysiological process of the disease. So if you manage type 2 diabetes without managing or hyperglycemia, without considering the weight, it is going to be detrimental to the process and the treatment. So compensatory eating for fear of hypoglycemia. If somebody is on hypoglycemic agents, excessive eating causes weight gain, which is again contradictory. As I said earlier, people who get obsessed with HbA1c try to lose weight by wrong methods, and that is again detrimental to the process of abnormalities in the metabolism that happens, which is the root cause of type 2 diabetes. So point number 5 is managing glucose without considering the weight is extremely harmful. Now, there is a very strong saying, I am sure all of us know, karmanye vadhikarasteshu ma phaleshu kadachan. So if you do the right karma, you don't really have to worry about the fruit. And the right karma is to deal with abnormalities in the weight, particularly in the fat. And once we deal with that, the glucose automatically gets to the place. May not get to the place that we want, because definitely we understand that there are some genetic, epigenetic abnormalities that cannot be managed or modified. Then rest of it can be managed by anti-diabetes therapy. But in type 2 diabetes, more important is to manage weight, more important is to manage fat, and then if the hyperglycemia remains, we can think about reducing the glucose by whatever therapy. Now, there are 3 points that I would like to make more. Does not mean glucose is not important, because severe hyperglycemia, acutely sick patients, type 1 diabetes might require management of glucose. Even in type 1 diabetes, management of weight is very important. Not only, as I said, not only high weight, but even low weight is a problem. So we manage weight, we don't lose weight. Don't take those terms in that sense. Weight management is not equal to weight loss, as I said. How to do weight loss is not considered here because of interest of time, because that is one point. If you lose weight wrongly, that's going to be a problem. But if you use the right methods, weight is more important than glucose. Now about history of diabetes, this is a slide, but it doesn't fit in my 10 minutes of debate. That is why I am not considering it here. I will talk about this slide in my rebuttal time. I have 20 seconds left, and here I am going to summarize the 5 points that I said. That the origin of disease starts with abnormal fat deposition, amount, and functioning. It's a multifaceted disease. We cannot only deal with glucose, we have to talk about weight. In spite of managing the glucose rightly, there will remain a residual risk if we do not consider the weight. We need a comprehensive care, not only metabolic, but also psychological and biomechanical, which will not happen without weight. We should try for remission, which happens with weight management and not the glucose management. And if we manage hyperglycemia without managing the weight, that is harmful and it can be considered as crime. With that, my time is over. Thank you so much.
Thank you. So let's call somebody from Bhubaneswar, going to the east coast of India, to answer or to defend glucose.
My slides, please.
Dr. Sandeep Das from Bhubaneswar, and he is going to defend glucose.
So a very good evening one and all, and at the outset I must thank Bansi sir for giving this opportunity and especially putting our talk at the first because I have to catch my flight. But nevertheless I will start with the same topic where madam has left. So I will highlight again the 3 points what you have told. It is management, it is type 2 diabetes, and what is more important. I think there is nothing clear in that sentence other than glucose control, because we are not comparing statin versus weight or something like that, targeting the risk factors and all. We are treating type 2 diabetes, and what is more important, it is nothing but glucose. So for the last few days I have been quite philosophical, and I'll tell why we are actually living and what are our needs in hierarchy mode. And many of you might have known about a terminology known as Maslow's hierarchy of needs, and it is a very worldwide accepted hierarchy terminology. So for a given human being, he requires psychological needs first, that requires roti, kapda, makan. So that is the first thing. Second is the safety needs. You require personal security, employment, resources and health. And the third is love and belongings, that's your family and belongings. And after all these three are met, you go to the tip of the iceberg, and that is your respect, your self-esteem, status, recognition, and finally to your full potential. So that is the Maslow's hierarchy of needs. Now, why I am telling about this? Because there is an absolute analogy with that of the glucose control also. So it's also a pyramid type of management, and the first one is fill needs for symptom control. See, someone is having diabetes, first control the symptoms. The second is glucose control and glucometabolic optimization. So glucose optimization is very, very important. And once these first two are met, then we go for the third thing. Third thing is also important. I completely agree with what madam has told. It is the barometabolic optimization and also the protection of other visceras, maybe viscerometabolic optimization. So let us come one by one. So first is the symptom control. So what symptoms we may get? It might be an hyperosmolar symptom, it might be a neuropathic symptom, or it might be a secondary infection control. So if I ask anyone in this crowd, everyone will tell it's not obesity which is going to be managed at that point, it is only the glucose control where you have to control your blood glucose. Now there would be psychological symptoms also, like distress, anxiety, depression, diabetes distress, disorderly eating and all. So there also glucose control is important, but again you have to be very careful in that you are not pushing the patient into hypoglycemia or you are not going into glycemic variability. So these two are very important. Now come to the hierarchy of that pyramid again. So come to the tip of the icing. So there we have dealt with three things. Again that comes in pyramid. First is vascular metabolic health, your micro and the macrovascular complication. Next is weight or the barometabolic health. And the third is viscerometabolic health. So what organ we are going to protect apart from the microvascular or the macrovascular health, maybe the skin, bone or the gonads or something like that. So but the first is vascular metabolic health. So vascular metabolic health in that hierarchy comes with microvascular protection and macrovascular protection. So we all know the complications of diabetes, and these are just the snapshot of what are the complications as per the as is found in India, that is neuropathy, nephropathy, retinopathy, peripheral vascular disease and coronary artery disease, and see the importance of that complication with the numbers given below. So let us come to the very basic trial, that is the UKPDS trial. So what they've done, they've intensively managed the diabetes patients in the initial part of diabetes in type 2 diabetes, and they found that any diabetes related endpoint, any microvascular events were significantly lowered with a good glycemic control. Those include retinopathy reduction and also albuminuria reduction. Myocardial infarction, the macrovascular complication, you can see the numbers have reduced, but they have not achieved the statistical significance with p-value of 0.05. So for microvascular complication, it is nothing but a good glycemic control which matters, and that all the trials have shown, say it UKPDS, DCCT, advanced accord, VADT, all have told that good glycemic control can reduce your microvascular complication. Now what about the macrovascular complication? There also good glycemic control reduces, but it is one of the most important factor apart from other factors like statins, BP control, or the secondary prevention of other drugs. So you have 43% amputation or peripheral arterial disease reduction, 12% stroke risk reduction, decrease in the heart attacks by 14%, and 21% diabetes related deaths, with all the macrovascular complication reducing significantly with 1% reduction in the HbA1c. And this snapshots everything, all the trials, and we have come across all these trials. We know that during the trial of UKPDS and DCCT, the microvascular complication has significantly reduced, but when this group of population have been followed for 10 years down the line, those who have been intensively treated or the glucose control has been done nicely from the very beginning, the macrovascular complication have also come down. So that is the conclusion from this slide. So what ma'am has told, that weight control controls all the complications. So I'll give you one of the best example for that, a very nicely done study, that is the Look Ahead research study which was published in NEJM, and that tried to see whether weight reduction with lifestyle modification is going to do any good to the heart or not, or the cardiovascular outcome or not. So you can see that in this trial with intensive lifestyle modification, the weight has significantly come down, the physical fitness have improved, the waist circumference have come down, glycated hemoglobin has also come down, but see what has happened, the cardiovascular outcome has not changed even at the end of 8 or 8.5 years. So that simply tells that only weight reduction is not going to control your microvascular. Stay away from microvascular, it's not going to reduce. Macrovascular complication also, it's not going to do any good. So these are the conclusion from that Look Ahead trial. So next, coming to that hierarchy, let us see about the barometabolic health, what madam has highlighted, and that has come at the tip of the iceberg where the importance is actually not that great. So we need avoiding weight gain and we need to avoid weight loss also. Lipid friendly should be there, and that can be well achieved with a good glucose control also. Plus weight loss is also important. I am not telling you managing weight is not important in patients with diabetes, that is important, but with weight friendly drugs. So we have drugs that reduces weight, but it is other intrinsic action that reduces all the complications. So say it's CVOT trials of SGLT2 or GLP-1 receptor agonist, it is not only weight that has reduced the complications. So coming to the viscerometabolic protection, we have liver protection, gonadal protection, bone health protection, and skin health. I am not going into details of that. And again here glucose control is very important. And there is a study which has shown glycemic control predicts severity of hepatocyte ballooning and hepatic fibrosis in non-alcoholic fatty liver disease. So it's also beneficial for the liver. Gonadal health, we know that good glycemic control increases the testosterone, and I'm not hypothesizing, these are all part of good and robust studies. Improve the fertility in women and improves the obstetric and fetal outcomes in patients with diabetes. So all these can be achieved with good glycemic control. And what madam has told is we are dealing with type 2 diabetes, we are not dealing with type 1 diabetes. And let me just show two screenshots in that. One size doesn't fit all, and that is, we know that from the clustering of diabetes that has been published in the Lancet maybe in 2018, where they have told that even in type 2 diabetic patients, 18% are severe insulin deficient, 39% insulin resistance is not the important factor. So almost like 60% do not require a weight reduction in that period of time. This is by Dr. Mohan et al. Again, the clustering of diabetes. Severe insulin deficient accounts for 26.2% 2% of type 2 diabetic patients in India, where weight reduction is not important, it is the glycemic control which is much more important, and mild age-related diabetes account for 35.8%. So summarizing my talk, so what we discussed about the Maslow's hierarchy, what a human being needs in his life, and that has been exactly extrapolated to a disease condition. We require a symptom control that has been endorsed not by Western guidelines, it is also endorsed by our RSSDI guideline that first target should be symptom control that can be achieved only with glucose control, psychological symptom control, microvascular protection. No one can argue that glucose control is not required. It is in fact the most important thing. Macrovascular protection, glucose control, and other organ protection like liver protection or the gonadal function, what I have discussed at the tip of the iceberg. So with that, glucose control is the key. Felt needs for symptom control, glucose control, vasculometabolic, barometabolic and viscerometabolic control, and the key is only glucose control. So with that I will end. Managing type 2 diabetes, what is more important, it's nothing but glucose. Thank you for the patient hearing.
Thank you, Dr. Sambit. Please stay on the dais and I'll call upon Dr. Anjali to have a very, very short rebuttal, less than 2 minutes.
Sure, sir. So 1 minute, sir. So Maslow's hierarchy of needs, he said that symptom control is required. I am sure all of us agree that most of our type 2 diabetes patients do not have any symptoms. So symptom control, unless the patient is acutely sick and severely hyperglycemic, which I said in my slides, will require glucose control. Percentage of the risk reduction that he showed of micro and macrovascular complications, 20%, 12%, 30%, 40%. We are forgetting that rest of 80%, 60%, 70% of the risk is remaining in spite of glucose control. And the answer there is going to be weight management. So only glucose control, the numbers they look very impressive with the way they are presented to us. We are forgetting that if 12% risk is reduced, 88% risk is still remaining, and that needs to be dealt with. And then we have intensive lifestyle management for look ahead was done for glucose management. The trial was not designed for weight management. So if we design a trial or if we design a therapy for weight management, not weight loss, then that is definitely going to be more useful than managing intensive lifestyle for glucose control. So it is not about how we do it, it is about what are we trying to achieve. And then managing weight is not only protective, preventive, but also therapeutic, and glucose control will automatically ensue. So with that, I'll hand over to Dr. Sambit for the rebuttal.
Yeah, I think I'll just ask one question to Madam. Just show me one trial where only the weight control is the primary target or the primary intervention, and what outcome they have produced. I'm not talking about GLP or SGLT2, and I am, in fact, just a minute. So in fact, in my presentation, I have, in that hierarchy, I have also clearly told that weight management is also important, but next to diabetes management, and we must use drugs that controls the blood glucose and also the weight. So that includes, obviously GLP and SGLT2 will definitely come, but only weight control that I have shown with the look ahead trial. And yeah.
So before we move, fine ma'am, before we move on to our two experts, we'll see whether it has changed the mood of the audience. I will request everybody to vote. Please don't sit on the fence. So those who are in favor of weight reduction, may raise the hand. And around 12, 12, 15. Those who are in favor of glucose reduction, well, it is practically 50-50. We'll have opinions of both the experts.
So we can share the prize.
So, I am the lawyer for the weight people, and Dr. Anjali have to pay a very hefty amount to my cashier, Dr. Manohar sitting. I am very costly lawyer. I'm not Kapil Sibal, of course. Well, so I have been sent here to defend weight versus glucose, and I would tell you from science perspective, and I would watch for weight. Simple reason, look at the evidence generated so far. Fine, somebody is symptomatic, having a hyperosmolar symptoms, of course you need to control blood glucose. They are having a catabolic state, we don't want to lose their body weight. So that's not in the discussion. It's a chronic case. First of all, 70% of people diagnosed diabetic are asymptomatic. So let's talk about majority. So barring those rare circumstances, when we are talking about chronic diabetes, glucose versus weight, the data is now very much tilted towards weight. Let's start from glucose. Glucose as a risk factor. Who studied that diabetes causes micro and macrovascular complications? There are number of studies. Let's start Salim Yusuf studies, inter-heart studies that looked for 9 modifiable risk factors way back in 2004. And after 12 years, there was another study conducted called inter-stroke study. There again same 9 risk factor was studied, that which risk factor causes more damage. I'm very short, I'm going to. So that includes obesity and diabetes. So if you compare 9 risk factor, diabetes was at number 7 in the inter-heart study and at number 9 in inter-stroke study causing the stroke or myocardial infarction. But obesity was at number 3 in both inter-heart and inter-stroke study. That's epidemiological study. Now come to the therapeutic aspect. Look at the advanced ACORD BADT, intensive glucose control versus conventional, no benefit. Sambit, you tried to show microvascular benefit, nothing happened. These all were neutral trial. The ACORD was stopped because of increase in death. In advanced and BADT there was no benefit seen. Later on, after in ACORD EON, people looked at albuminuria reduction. Albuminuria reduction is nothing an outcome. It's a very soft surrogate endpoint. So evidence also didn't suggest that if you lower blood glucose, you lower complications. You always bring UKPDS trial. At that point of time, you are in a KG going school. The UKPDS is the most flawed trial ever done in the planet. And that was in a pre-statin, pre-ARB ACE inhibitor era. Their outcome cannot be negated, discussed today. Having said that, paying due respect to the UKPDS trial, it did suggest that you can have again proteinuria reduction. Nothing else. Proteinuria reduction by glucose control is not a great benefit if you look at. In contrast, if you look at the body weight reduction, you don't need anything. You have got a direct benefit. So that, current balance goes in favor of body weight. Of course, we need to control both. I am not debating that, but I have to choose between weight and glucose. I will choose first body weight over the glucose.
So I am with Sambit and I totally disagree with whatever Dr. A.K. Singh just told you. I have been given the job. Reason being, there's absolutely no trial which has shown that weight loss alone prevents cardiovascular disease. I'll start fighting. You are getting confused. You are getting confused with using SGLT2, GLP-1 where there's 17%, 16% weight loss. They are not weight losing drugs. They are also having an effect on glycemia. So all the trials that you see, STEP trials and all the Mounjaro trials, Sermon trials, they also reduced HbA1c. So you cannot tease out, of course everybody in this room knows that both are important. I'm trying to sell glucose a little bit more than weight. UKPDS, no matter whatever Abdesh says, he was also in his, he was not even in school that time when he was done. No matter whatever you say, it still gives you the best data of getting good glycemic control early on. Don't bring in VADT and advance and ACORD. They are flawed trials. They were done when patients already were quite advanced in diabetes and established cardiovascular disease. We are talking about new onset type 2 diabetes. When a type 2 diabetic patient comes to you, he has not come for weight management, he has come for glucose management. Of course, use agents which bring down glucose as well as weight. So use SGLT2, use GLP-1. But if you do look ahead trial, give them nothing but make them lose weight, you will not prevent cardiovascular disease. That is, no matter, there were some flaws with look ahead trial, but look ahead was the largest trial which was stopped because of futility. They could not get cardiovascular. It showed benefits with regards to blood pressure reduction, lipid reduction, etc. So we will do both, but I would always think of glucose management when a patient of type 2 diabetes comes to me first, because as Sambit told, only 30 to 40% are obese. 6% are not.
I think it's time. No. It's time for us to conclude.
Please, no, please. Time to stop debate, we have got a lot of time to spend. So we'll stop the debate here. What I would just conclude is, previously we were glucose centric like Arjun, we were just aiming at glucose. We have been asked to broaden our horizon, that includes now weight and everything, but still, weight has not been our center at present. So I think both of us them are right. There is no sense in separating either to reduce weight or either to reduce glucose. We have to do both. Thank you very much. Thank you everyone.